Respiratory tract infections. So respiratory tract infection refers to any of the number of infectious disease involved in the respiratory tract. It is classified mainly into upper and lower respiratory tract infections. So upper respiratory tract infections, so you have to recall the anatomy. It can lead to sinusitis, rhinitis, pharyngitis, likewise up to vocal cords. Lower respiratory tract goes from the larynx, trachea, bronchi, bronchioles, and alveoli in lung parenchyma. So you can see here, alveolar duct and alveolus. Upper respiratory tract. Upper respiratory tract infections are the illness caused by acute infection which involves nose, sinus, pharynx, larynx, laryngitis, sinusitis, what I said, and also common cold. So here we can see haziness in the sinuses, sinusitis. Inflammation of air passages within the lungs. Lower respiratory tract infection associated with tracheitis, bronchitis, bronchiolitis, then pneumonitis, pneumonia. Common are the bronchitis and pneumonia. Bronchitis, it could be acute and chronic, but it's a associated with prolonged inflammatory process. Bronchitis, we divide acute and chronic. Virus, pollutants are the acute. Chronic, it's associated with COPD, like prolonged smoking, heavy exposure to pollution. So it's in acute bronchiolitis, but we don't normally treat. Bronchiolitis is there, but patient in chronic obstructive pulmonary disease, those having or chronic bronchitis, time to time they may be having acute attacks. So then it depends on the etiology, more often viral, but same time bacterial infection can cause. So for that we treat. You can see bronchial margins are there. That is widening the margins. Pneumonia, that is the most important. That is infection and inflammation in lung parenchyma, mainly in alveoli. In a normal stage, but in pneumonia, fluid filling airspace. Then oxygenation and perfusion mismatch is there often because this is the fluid or gas exchange margin. So if it is filled with fluid, the lung main function is disrupted or deteriorated. About the global scenario, pneumonia kills more children globally than HIV/AIDS, malaria, and measles combined. Yet little attention is given to pneumonia. That is the thing. Nowadays, pneumonia is broad because COVID-19 related. So anyway, viral pneumonia, bacterial pneumonias, anyway, infectious diseases are the number one kill in the world. So pneumonia is also top of the list. Other thing is over 2 million children die each year from pneumonia worldwide. This is a significant, considerable amount. So definitions and bit of clinical definition of pneumonia. Symptoms, fever and cough or difficulty in breathing. Signs, breathe in more than 15 infant age of 2 months up to 1 year. Breathe in more than 40 cycles per minute for children 1 to 5 years life. So this is the one. Severity again. There are indexes also there. We'll discuss once in there. Non-severe pneumonia and severe pneumonia. Danger signs, they are rare, but it's a clinical criteria perhaps. Sign and symptoms, maybe in a pneumonia patient can present with upper respiratory tract infection as well, but often patient comes with fever, difficulty in breathing, shortness of breathing, and production of purulent sputum. We'll say it goes with more often productive purulent, greenish like it goes to bacterial origin. If it is even if producing sputum, but initial stage, even viral, it can be clear, but in later secondary bacterial infection, as I said, it can go to mucoid and coid to purulent. So same time patient can associated with fever, low grade fever, as well as constitutional symptoms like loss of weight, loss of appetite, generalized body tiredness, body pain, backache, likewise anything possible. So pneumonia we classify different ways according to etiology: bacterial, viral, fungal, and mixed. Another way we define as community acquired pneumonia, hospital acquired pneumonia. Hospital acquired pneumonia we further divide. Once we are doing nosocomial infection lecture, you will understand further. We'll discuss bit about community acquired pneumonia. That is, patient acquired the condition while in community. So patient comes with the symptoms. But if you have a hospital acquired pneumonia, patient develops symptoms after 48 hours of admission. So it indicates patient has acquired the condition while in the hospital stay rather being from the community. So if it is, that's how we differentiate, but that is termed nosocomial pneumonia. Further, if patient has ventilated, following 48 hours after ventilation, if patient develop pneumonia, earlier patient has pneumonia, maybe intubated due to different reason, but later patient develops pneumonia, it's termed as ventilator associated pneumonia. Same thing here, okay, hospital acquired pneumonia, patient comes with urinary tract infection, but 48 hours after admission, patient develop pneumonia. That's what. But community acquired pneumonia, it's a clear-cut pneumonia. But anyway, all are pneumonias. Different etiologies are there. And also we classify community acquired pneumonia as typical and atypical pneumonia. Usually atypicals develop in healthy adults, young, and often having mild symptoms. Maybe patient comes with fever, generalized body aches, those things, but once we do a chest X-ray due to dry cough, patient may be having a large pneumonia or pacification of one lung. So that's termed as atypical pneumonia. Typical pneumonia often symptomatic. This is another classification, that is aspiration pneumonia. Maybe patients who are in alcohol withdrawal or maybe loss of consciousness, maybe having toxin, poisoning, self-poisoning. So they are more prone to develop aspiration pneumonia. It's a different entity. Okay. So you have to know community acquired pneumonia, hospital acquired pneumonia. Then community acquired pneumonia, typical and atypical. Hospital acquired pneumonia, just simply or maybe ventilator associated pneumonia. Bit of etiology and LRTI in community. It's there. Okay. Streptococcus pneumoniae, Haemophilus influenzae, Streptococcus aureus, Staphylococcus aureus, Legionella pneumophila, Moraxella categories. Those are the common ones. Usually CAP, same thing. Community acquired pneumonia, main organism is Streptococcus pneumoniae, then Haemophilus influenzae. About the typicals, Moraxella categories. Atypicals are there, like Mycoplasma pneumoniae, Chlamydophila or Chlamydia pneumoniae, Legionella pneumophila. So this is community acquired pneumonia who has been put into ICU. Okay, so patient presented with community acquired pneumonia, but severe form of pneumonia. So it is associated against strep pneumonia. What I said, same organism, may be different patients or people having different severity. So this is about atypicals. So you have to know about this mainly. Then it can be viruses and protozoa and fungi. This is the typical pneumonia, mainly what I said. You can see dry cough, gradual, sputum, purulent. Extrapulmonary symptoms may be prominent. This is not prominent maybe. So same thing, okay. Rickettsia can develop. Respiratory viruses, other viral agents like varicella zoster, this fungi. But hospital acquired pneumonia, it is mainly caused by hospital acquired. Patient comes for different thing, maybe urinary tract infection, maybe for the undergoing for the surgery, maybe following trauma, but no any lung pathology. But once admitted and patient develops following after 48 hours of admission features of pneumonia, and found out that in the chest X-ray there is opacification suggestive of hospital acquired pneumonia. So clinical signs as well as imaging studies as well as inflammatory markers, that's how we often diagnose. So it termed hospital associated or hospital acquired pneumonia. Common organisms are gram-negative aerobic bacilli such as Pseudomonas aeruginosa. Then E. coli, Klebsiella, Acinetobacter species can cause HAP as well as ventilator-associated pneumonia. Gram-positive cocci also there is Streptococcus and Staph aureus including MRSA because it's in hospital flora. Risk factors. Physical or close contact with someone with the upper respiratory tract infection. Poor hand washing. Nowadays, it's very much important, hand hygiene. Close contact with children in a group of settings, school or daycare centers. Contact with group of individuals in a close setting such as traveling tours, cruises. Smoking or passive smoking. Healthcare facilities, hospital, nursing homes are also at a high risk. Immunocompromised population invariably, such as HIV, who has organ transplanted, congenital immunodeficiencies, long-term steroid use for the rheumatoid arthritis or whatever inflammatory bowel disease, so they are at high risk. Just pathophysiology, bacteria and viruses, we'll say, direct hand contact. Oh, but that is a mode of transmission, not droplet. Enters into not by inhaling, that's the route of entry. Immune defenses. So there's an innate immune defense, hair lining, filters and traps some pathogens. Traps in upper respiratory tract which caused by mucus. That's the production of the upper respiratory tract. So junction of the posterior nose to pharynx. Impinge on the back of the throat, transport pathogen up to pharynx. Inflammatory response to immune system. Swelling, erythema, increase of mucus secretion and leads to fever. Similarly, about lower respiratory tract organisms in LRT leads to inflammation. So they produce bradykinin, histamine, and prostaglandins. Leads to increased capillary permeability. Same as inflammatory process here. Fluid, cellular exudation, edema of mucous membranes. Leads to hypersecretion of mucus. Leads to persistent cough. So it's there. About the hospital-acquired pneumonia, here crossover infection via medical care worker, visitor, medical instrument. Same thing, mode of transmission, route of entry and source of infection is different. Leads to colonization of the nasopharynx, colonization of the GI tract. So factors for opportunistic infection due to use of medical devices or procedures. Then it leads to environmental factor inhalation, endogenous like aspiration. That's how they develop pneumonia as well as ventilator-associated pneumonia. Then bacterial translocation. So that's how it goes. So about VAP, same. Host factors, prior antimicrobial therapy, invasive devices. Here almost the endotracheal tube is there, but we put a cuff, but time to time we release, but micro aspiration is possible. Medications altering gastric emptying and pH. So gastric contain the one which can cause aspiration. Leads to this due to there is anyway foreign device is there, that is CT tube. So they are prone to colonization aerodigestive tract from the aerodigestive tract board. Leads to aspiration. So same contaminated water, medication solution, respiratory therapy equipment, so also aspiration, inhalation. Ultimately, it leads to both arms to bronchiolitis. Then it can spread to lung, leads to pneumonia as well as maybe it can cause lung abscess as well. Depends on host system and lower respiratory tract defense mechanisms. Because anyway, patient is in a compromised state because patient is dependent. So patient's mucociliary exhalation is not working because patient is with the ET tube. And also position. Patient's lung muscles are not working properly, as well as patient in a supine posture. So, web. So you can see further where we use the cuff. But microaspirations come. Intubation procedure, biofilm formation. It can lead to, because this is a foreign material, it can lead to biofilm formation. Contaminated secretions ultimately, because usually it's lung below trachea, it's termed as sterile, but once organisms are there, they can develop infection. Complications, we can develop any pneumonia as pulmonary and extrapulmonary. Pulmonary, primary, can associated develops it can develop secondary bacterial pneumonia, or due to bacterial pneumonia, it can develop influenza pneumonia. Pulmonary superinfection with atypical pathogens, exacerbation of COPD and respiratory failure, adult respiratory distress syndrome and death. Acute respiratory distress syndrome, sorry. Extrapulmonary cardiac, pericarditis and myocarditis, it can develop. Or muscular, myositis and rhabdomyolysis. Neurologically, it can go to encephalitis, encephalomyelitis likewise. Pulmonary, further it can develop lung abscess, pleural effusion, think local and systemic. Diagnosis, main clinical, history and physical examination. Then, meanwhile, we do imaging studies and laboratory tests. Microbiology order is sputum, or maybe if viral suspecting, we do nasopharyngeal aspiration, or maybe urine antigen test. It's not available much in most laboratories, but we can do like for Legionella and strep pneumonia. Hematology and markers of inflammation, full blood count here, CRP and procalcitonin. Procalcitonin is PCT is a good marker of suggests pneumonia. Chest X-ray, CT, MRI depends. Often we prefer X-ray. And histopathology, it's a definitive diagnosis, but rarely done. Maybe following lung biopsy, V2. It's not rarely done for diagnostic. So here, physical examination of individual with upper respiratory tract. A doctor may look for swelling or redness inside wall of the nasal cavity, redness of the throat, that is features of tonsillitis or pharyngitis, enlargement of the tonsils, white secretion of the tonsils, likewise. So this is the way for the etiological diagnosis. We do gram stain and culture, blood cultures. Forgotten that, blood cultures. We often, because in patient comes with fever, antigen testing. Depends later on PCR, serology, bronchial lavage, bronchoscopy. So this is the algorithm, how we do. Usually depends, okay? But patient with LRTI, clinical assessment, clinical diagnosis of pneumonia, antibiotic always indicated at high risk of complication. So without pneumonia, with high risk of complications, we always, again, even without pneumonia, we do antibiotic. Consider point of care, CRP. CRP high, antibiotic. To consider delayed antibiotic. If less, do not totally give antibiotic. And if it is there's other way, if LRT without clinical lower respiratory tract without the pneumonia, self-limiting, do not totally offer or consider delayed antibiotic prescription. But that's while the monitoring the patient follow-up. Assessment about the pneumonia. There are different indexes. Pneumonia severity index. Get idea what is PSI. Based on the I score, we do recommendation site of care. That's very much important. Outpatient, inpatient, likewise. Same curve 65. Confusion, urea, respiratory rate, blood, systolic and diastolic blood pressure, and age. So we give points. If it is, we stratify them as risk group 1, 2, and 3. 1 low risk, 2 probably admission versus post outpatient management, or we have to decide 3 admission, manage as severe. Treatment, pharmacological and non-pharmacological. Non-pharmacological is supportive care. That is fluid treatment, dehydration prevention, vaporization, not dungatti, any mutti, whatever we can do. Pharmacological treatment, antipyretics, antihistamines, then antitussives, steroid decongestions. Then we go for treatment with antibiotic specific treatment. Usually empiric treatment, if in one patient, we go with 2 antibiotics, suspecting patients having pneumonia. We often give ceftriaxone with to cover common organisms like Streptococcus pneumoniae, Haemophilus pneumoniae, Moraxella catarrhalis, or even other gram negatives, plus to cover atypicals, organisms like Mycoplasma pneumoniae, Legionella pneumophila, or Chlamydia trachomatis, we give either macrolide, azithromycin or clarithromycin, or novel respiratory quinolone like levofloxacin. But levofloxacin, it's always discouraged, but It depends, okay, because it uses second line anti-TB therapy. But once we opt both therapies, but nowadays we often give antiviral as well, oseltamivir. But once we have excluded, we can omit that. So once we have in the target therapy, we can opt proper antibiotic therapy. Usually it goes with 7 days. Even with the clinical response, with the CRP response, we can convert into oral as well. It's better advice is 7 days. Usually these atypicals we give 5 days only, but if it is not required, because if we initially we have started with empirically imaging, then next 2 days later we found that patient is having Haemophilus influenza, so we don't need to continue clarithromycin, no levofloxacin, no azithromycin, we can omit that. That's how narrowing down therapy, because now reduce the number of antibiotics. That's how it goes, because once reducing the antibiotics number, it will helpful for, it's a rational use of antibiotics, what we discuss in antimicrobials. That's how it goes. Otherwise, if you give multiple antibiotics without target, it may invariably develop antimicrobial resistance. That's how it goes. So here, without comorbidities, we give amoxicillin. That's what I say. Severe combination therapy, beta-lactam plus macrolide. Beta-lactam is proper therapy is ceftriaxone or cefotaxime. Severe, again beta-lactam. Even we can offer meropenem. But if we are suspecting MRSA, we have to go with vancomycin. About community-acquired pneumonia, patient with CAP. No risk factors for Pseudomonas aeruginosa. We often give non-pseudomonal, non-anti-pseudomonal cephalosporin. What I said, ceftriaxone. If risk of Pseudomonas aeruginosa, Sri Lanka is less, but if patient has had recent admissions, but once they are, still we can't exclude as hospital-acquired pneumonia, but we are suspecting, so we often give carbapenem with ciprofloxacin. So there are the risk factors: COPD, bronchiectasis, recent hospitalization, recent antimicrobial therapy, suspected aspiration. Otherwise, we don't want to give anti-pseudomonal antibiotics for pneumonia. So here, MRSA, okay. Base risk of modeling infection with MRSA, vancomycin or linezolid. Not high risk modality, high risk MRSA. High risk modality, high risk MRSA. Not high risk modality, not high risk MRSA. We can go, but high risk MRSA, we can go into vancomycin or linezolid, that we are adding, okay, one anti-pseudomonal from column A or aztreonate, maybe piperacillin tazobactam with vancomycin. But we high risk, we are adding vancomycin or linezolid. Surgery, yes, it's rarely indicated unless patients having multiple lung abscesses or maybe concealed effusion where we need to, even ET tube can't reach, not ET tube, transthoracically what we are putting, we can't treat the fluid aspiration is cannot be achieved. So we often do surgical procedures. So once intercostal tube is not properly functioning, we can adjust, but maybe patient requires some surgeries. It depends, okay. If it is not responding, we offer. Monitor the response, what I said earlier. So this is very much important, but TB, we have to give at least 6 months. Depends, melioidosis, maybe pneumonia, we have to give at least bacterium without focus 21 days, followed by, that is ceftazidime or meropenem. Then we go for cotrimoxazole, double dose for, that is 19-20 milligram, 12 hourly per 90 days like. Thank you.